Let's wait a second that people are slowly, we're already at 224. We are filling up quickly our capacity. Yeah. Okay, we reached 500 and soon we will be able to, as soon as we hit the 1,000 mark, we will be able to start. Okay, let's start. So good morning, everyone. Welcome to this edition of the Data at Breakfast. Let me quickly introduce myself because I usually forget. My name is Francesco Petruccione, and I'm at the moment the Pro-Vice-Chancellor of UKZN for Big Data and Informatics. And the Data at Breakfast is an event that we started almost 2 years ago. And during these exceptional times of COVID, we increased the frequency from monthly to almost weekly. And we had already prominent speakers. And today we will have a very, very prominent one that I will introduce to you just now. We have a very large number of participants today. It's our world record. And we will, because of that, we will also make sure that the webinar will be available on, on YouTube just now. Just some simple instructions. Since participants don't have the right today to ask physically questions, they are welcome to use the question and answer facility of Zoom. And if you look at the bottom bar in your Zoom screen, there is a Q&A button. Yeah? And if you press that button, you will be able to pose your questions. Yeah? Some of you emailed me already yesterday and the day before yesterday questions. Yeah? But I would encourage you to please post them again in the question and answer facility so that it makes it easier to get the conversation going during the, during the webinar. Okay, let me introduce to you the today's speakers. Today's speaker is Professor Salim Abdool Karim, that is probably known to all of you, mainly because he chairs now the committee of the South African government to fight COVID, and you had probably opportunity to see his presentations a few days ago, which is also recorded on YouTube, and I hope that you did your homework and watched it before joining us here this morning. Professor Karim is the mainly probably one of his main accolades is that he's the director of CAPRISA, the Center for AIDS Program and Research in South Africa, but he's also professor at many universities worldwide, from Columbia University, Harvard, Cornell, and has many accolades that I won't list now, otherwise we will be here until tomorrow, just listing the accolades. And I'm really very grateful to Professor Karim to take time for us this morning, because we all know that he's very, very busy usually, and even more busy during these challenging times. So thank you very much, Professor Karim, for that. With us today is also Professor Tulio de Oliveira. And Tulio is a professor also at the Nelson Mandela School of Medicine at UKZN, and he's the director of CRISP, the KZN Research, Innovation and Sequencing Platform. Tulio will assist with the moderation of the questions, because it can be very stressful to look at the question and answer facility. So Tulio and I will try to channel questions to Professor Karim after his initial remarks. So I think I've spoken enough. You're not here to listen to me, but to Professor Karim. Professor Karim, please, we are very keen to hear your words. Thank you very much.
Well, a very good morning, one and all. It's a great pleasure and an honor to be with you here this morning. I have to start by expressing my disappointment and concern with Francesco and Tulio. They brought me here under false pretenses. I was clearly told that this is data at breakfast. They didn't explain to me that it meant that I needed to bring my own breakfast. and that there wasn't breakfast being provided. So I feel this is really false pretenses on their part. Having enjoyed my own breakfast, let me just make a few remarks. I hope most of you have had an opportunity to see the presentation I gave on Easter Monday with our Minister of Health, because I don't have anything more to say. What I needed to tell you is in that presentation. I laid it all out in one presentation. It took a bit long, I apologize, but it's covered in there. Perhaps just to make one point, that if we want to really grapple with this particular virus, that it is not a condition that we should underestimate. When you look at strategy and tactics, and you look at things like the art of war, and you're trying to understand your enemy, one of the biggest flaws in great generals is that they underestimate the enemy. And we should not do that with this virus. I say that because some people thought they could outwit this virus, that there was a way that you could get around it, and that you didn't need to really tackle it head on, and that you could either try and achieve herd immunity by just allowing natural infection, particularly in young people where the disease is quite mild, or you try partial protection measures while allowing spread to occur. And those partial protection measures largely focus around the elderly. Well, countries have tried those and have found that those strategies haven't really been effective. And I can elaborate on that if you want in the question time. But that those who've taken this condition seriously, who understood that its reproductive rate of between 2 and 3 gives it an edge over anything we could do in a population that has absolutely no protection, 0 antibodies that are effective against this virus. Everyone is a sitting duck. Everyone is at risk. And so you have to treat it like that. You have to treat it as a condition that everyone's at risk, everyone potentially is going to get infected, and you need to put in place measures that deal with that kind of approach. I've been studying viral diseases for many years. I first started studying a viral condition back in 1982. So I don't know how many years that is. It's almost 38 years or something. Started under Professor Jerry Kuvadia, my mentor and PhD supervisor, trying to understand the small measles outbreak in northern KwaZulu-Natal. And I remember that time, he and I were invited by the Minister of Health at the time. You won't know, you're too young, perhaps, called Rina Fenter. And we went to Parliament in Cape Town, Jerry and I, to meet with her. Because she was concerned. She was concerned about the measles epidemic. She was concerned about its impact, and she wanted some guidance about how to deal with this problem. And for us, it wasn't a political issue. If we could do anything to save the lives of children, we needed to do it. I subsequently studied, did some research on hepatitis B. I was involved in some of the polio eradication program work. I chaired the polio expert committee. And when I was chair of the National Advisory Group on Immunization with Barry Shube at the time, who was the head of the NICD, we spent many hours discussing pandemic flu preparedness. And we even purchased Tamiflu, and we had warehouses full of Tamiflu. We were so worried about a flu pandemic. And we put in place early warning systems to pick up the flu that's circulating in the season, and a whole range of pandemic flu preparedness activities. So in many ways, our country had already started preparing for pandemic flu. And I'm talking now about the 90s, the early 90s. So that's 30 odd years ago. I can tell you, nothing we did prepared us for this. Nothing. I mean, we had no real idea, actually, at the time, what was going to be needed by a respiratory virus that has a reproductive rate of somewhere between 2 and 3. We had no idea how fast it would move, how all-encompassing it is, and how we would just not be able to deal with the challenges that this would pose. Because all our thinking, all our ideas focused around flu. And flu moves much more slowly. Flu is also, it's a seasonal condition. We wait for the flu to come from the northern hemisphere, and then we get it in our winter months. So there's no question that we really were not ready for a virus like this. And the reality is actually no one was ready. No, nobody. Nobody ever thought that we would need to deal with something like this. We all thought we were going to deal with something like the flu. And even the US, which has among the best pandemic preparedness, well, you just need to look at their epidemic to know, how badly that's going. So I think that we as a nation needed to take this threat seriously. I'm impressed that the powers that be took it so seriously, and that they didn't need to be convinced, that they didn't need, and they didn't waffle around, they didn't procrastinate. They were decisive, they made decisions, they take the consequences of those decisions, and that they've taken us on a path that we are now trying to understand what happened because we didn't get the epidemic. And, we'll continually try to understand it. But I think I made it clear in my Easter Monday talk that we have not escaped this bullet. We simply have postponed it. I take the view that it's inevitable. We have a whole nation which has all the conditions for the spread of this virus. We have no protection in the form of a vaccine or natural antibodies. And so we're going to have to find a way to push it back as far as possible to give us time to prepare. Because we were never prepared for this. And in fact, no country was. And we've taken a slightly different approach from most other countries, in that we've chosen to be proactive. We've chosen to look very carefully at what the epidemic is doing. And we've chosen to titrate our response in relation to our understanding of where the epidemic is and where it's going. Whether we're right or wrong, time will tell. History will judge us. I don't claim that we are not making mistakes. If you don't make mistakes in tackling a disease of this nature, that means you're not being sufficiently proactive. If you're simply not making mistakes, it means you're not doing enough, because you have to do things to get ahead of this epidemic. And when you're trying to get ahead of this epidemic, you're doing things in a data-free zone. You don't know, in many instances, you actually don't know what the net effect is going to be. You have to try trial and error. You have to try something and it might not succeed. Well, you made a mistake, back to square one, let's try something else. This is not a time to put your hands up and say, oh, I don't know what to do. Well, if you do that, this virus is just going to overtake us. So I've been very fortunate that I really am just the spokesperson for many wonderful people who do all of the behind the scenes work. I have the pleasure and honor of working with 50 of our country's leading scientists, people who are really the brains trust of our country. And the minister had the farsightedness to bring them together in an advisory group to give him the best scientific information to help work out what should be the best of the bad options available to us. And I think we pretty much only have bad options. It's just a question of which is the least bad of them, and how can we try and work out what's our best way forward given the challenges. I think in all of this, that as I try and share my insights into what I've learned, and I was reminded the other day, I have zero standing in this field. I have not published a single paper on this coronavirus, not one. So if anybody had to try and use any definition of an expert, I would not meet any of it. I have zero credentials. In fact, my son, who is a student at UCT, has published more on the coronavirus than I have, because he works with Tulio, and Tulio has published more than anyone else I know on this topic. So really, I have zero credentials to talk to you today. I simply come to you as a scientist trying to understand this, and I'm happy to share with you whatever I've learned, with no pretensions that I am any particularly more knowledgeable on the subject than you are. I'll stop there.
Okay, thank you very much, Salim, for this very honest and humble description of the situation in which we are at the moment. Really much appreciated. You really made us clear where we are standing and the challenges that we are facing, and the scientific way, even if we are not experts, that we have to use to get out of this long dark tunnel. Can I ask now Tullio to start moderating the questions that many of you have already posed?
Okay, thank Francesco and thanks Salim. Yeah, I have organized the questions in many different categories. Yeah, and I will be asking by a specific category because it makes easier to Professor Salim Karim to answer that. So the first category that I would like to ask 2 questions to Professor Karim, it is on the lockdown, especially that today should be the day that we are releasing the lockdown and the government decide to extend, yeah. And my questions will be mostly about data. So the first question, Professor Karim, yeah, what do you think accounts for the significantly higher infection count over the last week or so compared to the start of the lockdown?
Okay. So not only is it that you don't even give me breakfast and bring me here under false pretenses, you start by asking me the most difficult question first. This is like, it's for every one of you on this particular Zoom call, if you are invited to come and do this session, just remember about these 2 guys and how they bring you under false pretenses and then threw you under the bus with the first question. Okay, so let's tackle the problem.
Okay.
When we look at this particular disease, we have to understand that when we see a case today, a case that we are counting today, it is a case that is counted from a positive lab result. In other words, the lab showed that the PCR was positive. So because you count a case from the time that there's a positive lab result, your actual infection occurred on average about 2 weeks ago. I mean, it could be anything from about a week to 3 weeks actually, but on average, it's about 2 weeks ago. So the 2-week shift is what you keep need to thinking about. And I tried to explain this, but many people didn't quite grasp this, the subtlety that when you look at all of the cases that occurred per day in the period up to the lockdown, we were actually looking at cases per day that in that period reflecting infections that occurred prior to the state of disaster. It's because you have to shift it 2 weeks earlier. So all of those infections, all of those cases we saw up to the date of the lockdown, they occurred about 2 weeks earlier. So that means that the first 2 weeks of cases that we see after the lockdown actually occurred on average before the lockdown. And probably the tail end, the last week of the 2 weeks, the last few days of those 2 weeks, is a mingling of cases of infected. Those cases reflect infections that occurred around the time of the lockdown and soon thereafter. But you can say, if you just work with that 2-week shift. So that means that the 3rd week, or after the lockdown, is probably our best indicator of infections that occurred straight after the lockdown. That's probably the best indication. Again, there are many caveats to that, but if you work with that as a reasonable assumption, it gives us some idea of where we are. So what would I have expected? I would have expected that if our state of disaster did not work, we would not see the downward trend before and after the lockdown. So the initial drop that I showed is not due to the lockdown, it's due to the state of disaster. The tail end of that benefit, and there is a continuing benefit at the tail end of those 2 weeks, that is a combination of the state of disaster. And remember, the state of disaster was closing the airports, reducing gatherings, closing the schools, and social distancing, and so on. So we know that the state of disaster had quite a marked impact. In fact, so marked that it took our daily number of cases to quite a low level. When you look at such a low level, hovering around the 60, 70, 80 cases per day, now there's a lot of daily fluctuations, and you shouldn't allow that to bother you. You must expect that. You know, laboratories work in that kind of way, that it's not designed, like a car line where, you can standardize the throughput. Labs work in a way that, some days they get many runs and other days they don't. So there's going to be a lot of fluctuation. But on average, we see about that many cases. So now this week gives us a better indication. The thing about it is that we had such a strong effect of the state of disaster that there's not much more that the lockdown, there's not much room for the lockdown to drop the cases even more. So when we look at the cases we've seen in this last week, I bet all of you have been wondering, why is it so often above the 90 mark, which was the benchmark I set? Well, the problem, very fundamentally, is that we initiated a community health worker program. And that program started and coincided with this third week. So the community screening, the door-to-door screening, and then the symptom screening and the referrals now only occurred in this third week. So that now has muddied the waters. What you are seeing is the cases that occurred as a result of the standard passive reporting. Because up to the second week after the lockdown, when we counted cases, they were all passive cases. They were people who got sick, came to the hospital, came to their doctor's rooms, got tested, and that's how we discovered them. We also have a bit of context where we go and trace, but it's not anywhere near the sort of standard discovery that we have through passive reporting. So suddenly in this third week, we now have a whole new reporting method, active reporting, active case finding. We're going out there into the community looking for cases. And if we look at that situation, up to yesterday, or as a day before yesterday, I stand to be corrected, the community healthcare workers, and there are thousands of them in the field, have screened about 1 million people. That's a lot of people. They have screened 1 million people. The target is to do 1 million a week, at least, right? 1 million a week. But they've done about 1 million in the last 6-7 days. And they've referred just over 10,000 people for testing. So suddenly, we now have more testing to do. And those results, whatever they are now mixed up in the passive reporting because we can't distinguish them. We tried in different ways to distinguish which were from active case finding and which are from passive case finding. It's very hard to distinguish them. So now it's all mixed up. So when you compare the number of cases in the third week compared to the number of cases in the second week, we are not comparing apples and apples. We are in effect comparing apples in the second week, and in the third week, we have apples and we have oranges. And so the apples and oranges, we can't really tease them out. So we have to look at it together. So now we've got all this apples and oranges. If we really want to compare apples and apples, we need some way to tease the two out. We need some filter that can sift out the oranges so we can focus on the apples. Don't have that. And so we're trying our best right now. I'm trying to make some estimates. I'm trying to look at the problem from different ways. And I'm hoping to share that as soon as we have an answer. But I wouldn't be concerned and think, oh, it's more than 90, oh, we're gonna be in trouble. It's not, that's too simplistic a way of looking at data. When you look at data, you have to understand its source, you have to understand its comparability before you simply compare. And I didn't factor that into my thinking. Again, remember I told you you're gonna make mistakes? Okay, notch that mistake up to me. Slim gets one cross against his name because he blundered in terms of not factoring in the active case finding when he talked about setting a target.
Okay, yeah, thank Professor Karim. Yeah, your answer led me perfectly to the second question. Yeah, and it's gonna be the last one about testing. Yeah. So given that we are now not talking about the magic number 90, where to explain quite well, can you just comment to us a little bit about the increase of the public health testing? And if maybe we're gonna start looking at different statistics, such as the percentage of positive cases that we screen, and how do you see this new data coming, and what's the importance now to tease it, as you say, apples from oranges, and when you tease the private testing from now the increasing public testing?
So one of the additional problems in comparing the third week to the other weeks is that the source of the tests has steadily been changing. And it's been changing because I don't know if you can visualize my diagram from the Easter Monday presentation. I talked about the first wave, the blue wave, where it was really the travelers. Then I talked about the red wave, which is the contacts of the travelers. And then I talked about the green wave, which is the general population. So the private labs were largely responsible for uncovering and giving us the information on the first wave. So the first wave, because many of those people who traveled had medical aid, they went to the private labs and they got a result. At that time, the NHLS was operating under an NICD definition that was really quite inflexible and deliberately tried to hold back on the testing and tried to keep the number of tests we did down to a minimum. And so we were only doing, as a whole nation, the public labs were only doing 100, 200 tests a day, which is scandalous in my view. So we were only able to change those criteria barely about 2 weeks ago, even less. So our criteria had to change. The moment our criterion changed, we now open the doors. So we now have a different set of samples coming in. And because of that first wave coming to an end, and that first wave has to come to an end because we stopped the traveling, we're now no longer seeing that first wave in the private sector. We're now seeing parts of the second wave in the private sector, but we're also seeing part of the second wave in the public sector. And so now the cases that we are finding are coming from that second wave, and they are coming from that third wave, the green little line at the bottom. And when we look at that, the steady increase in the number of tests being done by the public service, the National Health Laboratory Service, that tells us that we can't simply compare the third week to the second week. Again, remember, when we compare, we have to know the source of the samples, and we have to know the patient mix, the case mix. We need to know where they come from and who they are. Otherwise, you're not comparing the same apples. You're comparing Granny Smith apples with Star King apples, right? So you're comparing two different kinds of apples. And so we need to be very careful with that. So there are many caveats to just to looking at trends that are not answered by just looking at things in a simplistic way, that I might have, in my effort to convey it to the public, I might have oversimplified it. It's actually much more complicated. There are ways in which we can deal with this. I mean, none of this, you know, is a complete train smash. We're smart people. We can figure this out, and so we have ways of doing that. And one of the ways, of course, is to do a stratified analysis. So if you stratify your data, you get rid of the mixing effect. You get rid of the confounding. And by stratifying it and looking at strata, you have a better idea of a more homogeneous group to look at. And so that's one of the strategies we have available to us. How we'll use it, whether we use it, I'm not sure yet. We'll know in a bit.
Okay, thank you very much for the comprehensive answer. So as you comment, this is a moving target, and it's very important, very good data analysis in real time in South Africa. So my next question from one of the participants, yeah. Can you talk what is the current strategy on how we're gonna deal with the waves of increased number of infections once the lockdown is lifted? More specifically, what you define in the plan at the stage 5 of identifying hotspots and control these hotspots and fires quick.
So in trying to devise what our strategy should be, I tried to define the 8 stages of what we need to do. And they're not sequential. I provided a diagram to show that they're not, you don't finish one and then start the next one. They overlap quite a bit. In looking at what is likely to happen after the lockdown, and you know, we have no idea what it will be, but we can make some guesses at what it might look like. And we are potentially going to see a rise in the cases. We're going to see what is happening to that green line. Is that green line still going to hover at the bottom, or is that green line going to take off? If you are a betting person, I would put my money on it taking off. I don't think we have much prospect of preventing it from taking off? Well, we're just not going to sit by and just let it take off. We have a strategy, and that strategy is again a community-based strategy, and that strategy is about identifying hotspots. We have put in place at the CSIR, and we did this actually on the first day I was appointed to chair this committee. On the first day, at the first meeting, we had a discussion with Imran Patel from the Department of Science and Innovation. And he talked about the CSIR had this capability that was built actually for the World Cup. You know, the Soccer World Cup in 2010? So the CSIR built this amazing capacity of a whole ops center for the Soccer World Cup. And it's basically walls full of television screens, huge maps of the country, various sets of data being shown. We can see everything there. I mean, I can tell you where the police stations are. I can tell you where the troops are moving. I can tell you whatever you want to know, it's on that screen. The thing that was missing from that screen is where are the cases? And so that's what we've been doing now. So we've been putting the information into that system. So as part of the screening that is being done, we're using cell phone technology. So the community health workers have to enter the information on a cell phone. And when they press submit, the cell phone sends a location, not just that this person has been screened, but it sends a location. That location pings itself at the CSIR. So we now know where we have covered the country with our screening. Now the system I'm describing, I have to tell you, is not fully in place because we don't have enough cell phones yet. And the cell phones that we got, 20,000 or so, had to be charged, the software had to be loaded, all that takes a lot of time. And so we started often with paper systems, but then as the cell phones have become available, they've now been dished out. So if you go to our ops center at the CSIR, at our fingertips, I can tell you where the hotspots are. I can tell you geographically where the cases are. I can tell you where we've covered with our screening. I can tell you where we have gaps. And when I talk about how are we going to tackle this problem, that's how we're going to tackle this problem. We're going to tackle it by using data. We're going to tackle it because we will have knowledge about where we are going at our fingertips, and so we can make smart decisions and try to keep one step ahead of this virus as much as we can. There's going to come a time where we can't. But until that point comes, our hotspot strategy should go some way to flattening that curve. I'll stop there.
Okay, yeah, thank you very much for the answer. And that leads perfectly to my third question. So in the last 2 weeks, the country have heard about hospital outbreaks, about outbreaks on jails, yeah, or in a jail at least. So can you just describe to us also what's the importance to collect diligent, accurate data to stop these outbreaks, but also to devise systems to avoid that happen in the country?
You can't have a respiratory spread virus and not have outbreaks. That's how the virus spreads. Right? It spreads through these kinds of outbreaks, and you get the super spreaders that will infect a lot of people. So that's just part and parcel of what to expect. Now, when you look at these outbreaks, each one of them is an education. They are guiding us as to how this virus is spreading and where we have weak links in our chain of protection against this virus. So in a way, if you think about our strategy of containment of this virus, like a dike, right? So we are holding back in a dam, we are holding back the water. Every time we get an outbreak, it's a little hole in the dam wall. And so we need to see where the water is coming out, because if we don't see where the water is coming out, we don't know that there's a hole there. But once we know where the hole is, we have to go and tackle it. And we have to find a way to plug the hole, or to find a way to stop the small hole before it becomes a big hole. And that's our strategy. I'm using that analogy to tell you about our strategy in terms of slowing the outbreaks. And so every time we go to a hole in the wall, every time we go to an outbreak, we're not just trying to slow viral spread in that outbreak, we're also trying to learn about how this outbreak occurred and what do we need to do to prevent more of those holes from coming about. The prisons are a major challenge for us. I mean, in the nature of this virus, in any situation where you have difficulty with social distancing, you're going to have a problem. Now, fortunately, well, maybe the word is not fortunately, that's a wrong way of describing it. But in the way in which our prison system works, we have a situation where there is some measure of social distancing, but there is too much of sharing of individual cells. And there are often too many people for the size of cell that we have. So we are creating the conditions for this virus to spread in those settings. And if we're going to stop these outbreaks from occurring, either in our hospitals, in our prisons, or in our mines, or wherever they're going to be, we are going to have to be much more aggressive in our testing strategy. We're going to have to be much more aggressive in our infection control. If ever there was a time for us to have really good infection control policies and enforcement, now is the time.
Yep. Thank you very much, Professor Karim. Yeah, there is a few questions, or many questions, about the role of HIV on COVID infection and also development of disease. Can you explain to us, do we have any how many HIV infected people are also infected with this virus, the COVID-19, and if we have, what knowledge we have of the severity of infection?
I've been asked that quite a lot because for obvious reasons, that South Africa has the biggest HIV epidemic. And so we're going to have the biggest problem of co-infection. We really don't know in any real evidentiary way about how this coronavirus is going to impact in patients with HIV. In fact, as I think I mentioned previously, we've been having conference calls, video links with our colleagues in China. And these are excellent sessions that we have with them. They bring all of their top epidemiologists and clinicians, and they share with us insights, because they're 4 months ahead of us. So they can teach us things that we don't need to make the same mistakes and repeat their mistakes. So they've been very helpful. So on the last call with our colleagues from Shanghai CDC, when they were asked, what was their experience of this viral infection in HIV patients, they told us that in the thousands of patients that they've had, they have only a record of having one person who had both HIV and the coronavirus, and he had an uneventful clinical course. So basically, we learned from the Chinese, but they didn't get any, and they didn't have any cases of co-infection. So I guess we're gonna have to study it here. We're gonna have to figure it out here. And we're gonna have to find out what's going on here. To date, because our first wave occurred in a demographic that doesn't have much HIV, we haven't really seen much HIV coronavirus co-infection. But the second wave, we're starting to see such cases. No early warning signs yet. So I haven't, from all the clinicians on the committee who share their wisdom and their experiences with us, we don't have any reason to be concerned at this time. If I was to guess, and it's purely speculation, I have no data. If I was to speculate as to what we can expect, I think we might find that those HIV patients who are on ART and who have reasonable CD4 counts, we should expect that they will have probably a close to normal course of disease, maybe slightly worse than HIV negative people. My big concern is about HIV positive patients who are not on ART and who have CD4 counts, below 300, 350. I'm concerned about them because I'm concerned that they might have a clinical course that is more in keeping with what we saw with the elderly. In other words, case fatality rates that start climbing and a much more severe course of disease. If that pans out, we're going to have a problem on our hands because there's a lot of those people. A rough guess says that of the 2 to 2.5 million people in our country who have HIV and are not on ART, that probably somewhere around 500,000 have low CD4 counts. So you can imagine what we may be heading into in that kind of scenario. I hope I'm wrong, but if I was to speculate, that's what I would be concerned about. Okay. So we've got 3 minutes left.
Yeah, so I have my last question because I think that's an important one. There is many questions about availability of data, which I personally disagree because we have put a big data team with Francesco and we can access very easily open data, and also we can also access very open data and communication from our health minister that every day give a briefing, or even about yourself that despite being very busy, it is really strongly communicating the result. Can you just finish this session, just say what's the importance of continuous communication, analysis of proper data, and data being made available to really control this outbreak?
I'm a big believer that every person in this world is a scientist. We were all born with an inherent curiosity to discover our world. And as we were little kids, we saw things on the ground and we went and investigated them. We saw a light switch and we would go and press it continuously to wonder why pressing the light switch puts the light on. We would go and see a little worm in the garden and go and pick it up to go and investigate it. We are inherently a curious species. So all of us are scientists. All of us can grapple with the curiosities of our world. And all of us have a sense of rationality, that we would like to know why things are being done. And we want a level of accountability for what is being done. We want to know that what you're doing has sufficient grounds in terms of being reasonable, and that the evidence, the information available can justify that this action was taken. Now, I can't even start to tell you how much we do in the Ministerial Advisory Committee, called the MAC. I mean, I can tell you, let me give you an example. 2 nights ago, it sort of feels like last night because it was still ringing with it. The MAC, all 51 of us, we had a meeting with all of the MECs and the minister and the deputy minister and the DG and the deputy DG. They all were there. Every provincial MEC was there. And they took, an hour and a half to tell us in detail what their problems are on the ground. Right? And they conveyed that to us so that we can understand what solutions they're looking for. In that call, I made a list of 17 items of things we now need to go and investigate. And we get questions, and only 2 people are allowed to give us questions. The minister and the DG. The acting DG and the minister are the only people. We do not take questions from the public or from any other department or from anyone else. We are a ministerial advisory committee. The minister bombards us every day with several questions. I put small teams together repeatedly in the course of a day because our turnaround is we average around 12 hours. So within 12 hours of getting the question, we will have a team of people who will go and investigate what the evidence is, and then they will provide a response. And some of the responses, some of the questions are big questions, some are small questions. So a small question is something like, should SAA crew have a 14-day quarantine period, isolation period when they come back from their travels overseas? Now, it's not a difficult question to answer, but we put a team together. They worked with SAA. SAA had some ideas about how to solve the problem. And our team then sent a set of recommendations to our minister to convey to the powers that be about what our expectation is about what SAA crew will do. On the other hand, we have big problems to solve, like gloves and masks. And there, we did very detailed investigations. We commissioned 2 Cochrane reviews, not the full Cochrane review, but a meta-analysis. So very detailed information. I mean, piles of stuff coming in, and we have to sift through all of that. And that we did in a big committee because there was just too much to do. And after it took us, that took us more than 48 hours actually, because we were waiting for WHO to give us guidance as well. We didn't want to do something until WHO gave us clarity. WHO basically put out a non-recommendation. They basically didn't say anything. So we were left now to make a decision. And we make these decisions, and then we convey that as an advisory to the Department of Health, and then they decide what they want to do with it. But to date, every advisory we have provided, and there are lots, not one of them has been rejected. The ministry has acted on every one of our advisories. So I feel that this is definitely worth doing. And we call on all kinds of outside experts. you know, when we were trying to grapple with chloroquine, we roped in that chap, Andy Gray from UKZN. And we drew on quite a lot of UKZN people. We draw on people from UCT. When we were talking about masks, we asked Max Price, the ex-Vice-Chancellor of UCT, to come and help us. We draw in all kinds of people to come and help us provide the best possible scientific advice. And so all I can say to you is that we depend very heavily on data. And there is almost no advisory that we put out that's based on expert opinion solely. Even if it's data on measles virus, or measles data on HIV or some other virus, we will draw on that data. Even if it's to say that that data is not applicable, we will draw on it. And I think that's particularly important for all of you on this webinar to be aware of. That you might not know it, but everything you do that's related to this, we have teams of people collecting that information and keeping it for us and collating it for us. And we draw very heavily on all of your work. I want to just use this opportunity to thank all of you, academics, students, all of you who are seeing patients, who are drawing on those experiences, who are dealing with the public health measures of being on the ground. And I'm not talking about those who are sitting in their offices and, you know, pontificating about the world. I'm talking about those who are rolling up their sleeves and are on the ground dealing with this problem. That's what we're interested in. That's what we really depend on. It's somebody who's not telling us the high-flying ideas, because ideas are dime a dozen. Everybody's got them. I mean, I'm amazed at the number of armchair experts. You know, after my Monday talk, I got thousands of emails. Thousands, I can't even go through them. Thousands of emails about people who have every kind of solution. They know how to cure this disease. They know how to stop this disease. They're a dime a dozen. I have no interest in that. I'm interested in your data. Thank you.
Thank you very much, Professor Karim, for your really comprehensive and insightful and motivating analysis of our COVID crisis. But also thank you very much for sharing some of your personal anecdotes and views and bringing us a little bit, giving a little peek to what happens behind the scenes, behind the curtains of the team that is trying to defend us from this virus. And but I also would like to thank you for the case you are making of evidence-based scientific method to tackle the big challenges of these times. Mainly because, you know, until probably a few months ago, most of us couldn't hear anymore the buzzword of big data. Yeah, it was something that we were bombarded with from the media, the newspapers. But now we are really in the position where we see that without big data, we won't be able to solve the problems that we are facing. And it's really crucial that we go back to the roots of our good old scientific methods and apply it carefully to our current situation. And hopefully this will be also motivation for many young people to approach science as a career. Yeah, so that that will probably help us solve also many other problems that we're facing as well. So Professor Karim, thank you very much again for your time. We really all appreciate it very, very, very much. And we are very happy to have you defending us from the virus out there. So thank you very much again to you, and thank you very much to Tullio as well for collecting so nicely the hundreds of questions that we receive and putting them together in a coherent flow of thought. So thank you very much again to both of you. Thank you very much also to some other people like Ilya and Kimara, who in the background organized everything. And thank you, of course, to all the participants. We will make now this presentation available on YouTube, so that people that were not lucky to experience this live will have the possibility to watch it later on during the day. So thank you very much again to all of you, and have a good and safe day. Thank you very much. Bye-bye.